Hello, and welcome to the Feeling Good podcast, where you can learn powerful techniques to change the way you feel. I am your host, Rhonda Borowski, and joining me here in the Murrieta studio is Dr. David Burns. Dr. David Burns is a pioneer in the development of cognitive behavioral therapy and the creator of the new teen therapy. He is the author of Feeling Good, which has sold over 5 million copies in the United States and has been translated into over 30 languages. David is currently an emeritus adjunct professor of clinical psychiatry at Stanford University School of Medicine. Hi, David.
Hello, Rhonda.
We have two honored guests today. Of course, our fabulous frequent guest, or maybe your another co-host, Dave Freibush.
I'll be whatever you need me to be, Rhonda.
Oh, don't tell my husband.
Deal.
And hello, Dave.
Hello, David.
And we also have a really wonderful honored guest, Amir Sabouri, who is an MD, PhD, and his specialty, he's a neurologist whose specialty is neuromuscular specialty.
Yeah.
And you treat people who have Lou Gehrig's disease?
That's correct.
Yes. And Amir was just telling us that he did his medical school training in Iran.
That's correct, yeah.
And then he went to Japan, where he earned a PhD in cellular and molecular neuroimmunology.
That's correct.
Then you came to the United States for a postdoc, and that's where you did your medical residency, correct, at UC San Diego?
I did my residency in UC San Diego in neurology, yeah, but when I came first to United States, I came as a scientist and I did research. So later I went to residency and did my residency training in neurology in the United States. That's correct, yeah.
And then you did a fellowship after your neurology residency at
That's
the
correct.
Washington University in St. Louis.
That's correct, yeah.
Nice.
Yeah, thank you for introduction.
Yes.
Yeah.
So we have two really great endorsements to read first before we begin.
We'll just do one on this podcast and one on the next. I was just joking around.
Oh, okay.
Do the little short one.
Okay. So this is from Pam. And Pam wrote, I love your work, Dr. Burns. I discovered your book, Feeling Good, online after searching for help with my low self-esteem because I have been unsuccessful all my life with relationships. Looking for guidance on how to help myself, knowing what to do, but finding it hard to do. Your book covers my insecurities and is just fabulous, as my low moods are because of how I allow others to treat me. Thank you so much. I almost want to carry it with me always. Very grateful, Pam.
I just say thank you, Pam, and to all of you who are sending in so many wonderful, encouraging comments, which I appreciate. I know Rhonda appreciates too. One really neat thing happened this week. I noticed, I've been saying in general that if you like the podcast, to tell your friends, because you're a form of marketing, because I'm not real good at marketing. Hopefully that'll improve soon. But right now it's word of mouth. And this week, all of a sudden on 2 days, the hits on my website quadrupled from the previous record high, which was 2,500 hits a day, and we got almost 8 or 9,000 hits one day.
Wow. And
almost as many the next day. Like it just dwarfed previous traffic. And the same on the podcasts. Just the downloads just mushroomed 2 days this week, and they weren't even days that are supposed to be high. Usually Mondays are a big podcast day, and then Wednesday and Thursday just went through the roof. And all we can figure is that one of you podcast listeners must have sent out to your emailing list. You must have a huge emailing list, and told people to go to my website to the list of Feeling Good podcasts. And probably sent the link. And then thousands of people went and did that. And I'm so grateful. If you know who you are, who did this wonderful gift to us, please email me so I can thank you personally. But it also occurred to me that probably most of you listeners have email lists that you belong to. And no matter if they're plumbers or psychiatrists or music lovers, it's a sure certainty that a third of the people on your list on any given day are experiencing elevated symptoms of depression or anxiety or both. And so if you were to send them the link to www.feelinggood.com and tell them to go to the Feeling Good list of Feeling Good podcasts, then that would benefit people because they're going to get all this help for free of charge, and it would certainly help us grow our market. So thank you so much for that support, which is
incredibly helpful
yeah,
and
it's
wonderful,
been
flattering.
amazing, and because of that, we'll go this month over 100,000 downloads
Wow.
on the Feeling Good podcast for the first time.
Yeah,
It's projected.
That's exciting.
Yeah, it's amazing.
Yeah.
But I
Well, let me
promise.
just say first that this is episode 173. I forgot to mention that.
Oh yeah, number 173. Now this is a podcast I've wanted to do with you, Amir, for some time, and finally twisted your arm to get you to.
Sure, it's my pleasure.
Yeah, right. And I supervised Amir's wonderful wife, Sepida, when she was a Stanford psychiatric resident. She's also an MD, PhD, and now she's on the faculty at Stanford. And once you came on a hike when you were still living in I think Washington or St. Louis.
Yeah.
And we really hit it off. And then when you finally were able to come back here and reunite with Sepida after separation for academic necessity, it was just fantastic. And you were coming on the hikes and began to do some personal work as we do, and then learning the 5 secrets of effective communication. And I just loved working with you because one of my favorite things has been the role for human skills in doctors, in medical doctors. And we were never taught this in medical school, and it still isn't taught in any meaningful way, but how to really communicate with patients and how to make that doctor's bedside manner come to life in a really healing way. And so we've had so many fabulous dialogues, and Rhonda made me promise not to say that you were one of the world's top neurologists, top experts in these rare neuromuscular disorders. And so I will not say that, just as I promised, but someone with less more sophistication might not say that, but that's really pretty much a true statement.
I'm sure your audience know that you make a lot of joke in your podcast.
Yeah,
so
but this is not one of my jokes. But I admire you as a friend, as a human being, and it's just incredible, the amazing skill that you brought. But the first time you came on a hike, you were actually depressed, not clinically depressed or sobbing or something like that, but feeling like a failure.
That's right.
And one of the reasons was because you're working every day with people with terminal illnesses, and your job is to tell them that this symptom that you have is an irreversible kind of hopeless neurologic disorder, like the horrible Lou Gehrig's disease, and it was just killing you to be having to say this to people, and you felt guilty and ashamed and inadequate, thinking that you had nothing to offer your patients. And that was the first of, I would say, 3 amazing hikes that we had. Can you tell us kind of how you experienced that and kind of what we came up with?
Yeah. So first of all, I'd like to thank you for everything and every help that you have given to us and providing. I feel so fortunate to be able to know you and to work with you and learn from you basically on a weekly basis during the wonderful Sunday hikes. Yes, that's what you mentioned is totally true. So I am a neuromuscular specialist, and one of the patients that I see, one of the type of the diseases that I see is Lou Gehrig disease, which is a basically a diagnosis with no cure, and in most cases, or I should say in all cases, if the diagnosis is definite, that means like sort of a death sentence to the patients. And I have, I went to medical school, and to residency and to fellowship. And my goal, and I think that's probably true for almost all physicians, is that to go and try to help the people, help the patients who needs doctors. And what I faced when I come to the real world and notice that with the ALS or Lou Gehrig disease patients, I felt that I am paralyzed, sort of. I tried to hide this part of my feeling in front of the patients, but...
And what were the feelings you were feeling you had to hide?
I felt that I'm not helping them. I thought that what I'm doing, with all of the training, is like what kind of change I'm doing in these patients' life, because I'm not curing them. I basically do nothing. I felt inadequate. I felt guilty.
Sad,
I felt sad and depressed and frustrated at myself sometimes.
Anxious.
And anxious to the patients. And I felt almost sometimes embarrassed that when somebody is like desperately needing my help and I'm not being able to provide that help that they asked. So it was very hard feeling for me. And I was carrying that sad and frustrated and feeling inadequate or ineffective, inefficient with myself to my home and to the next day, and that was part of my feeling.
And just to bring this alive a little bit for our listeners, you can imagine being someone like Amir, probably a genius IQ or something way up there, studying in multiple different countries, getting PhD, MD, a star in molecular biology, molecular pathology, all this fantastic knowledge acquired for great difficulty, and then feeling I have nothing to offer.
I'm inadequate.
Yeah, I'm inadequate, and just feeling like a failure. So many of us feel like failures.
Right.
So many people listening, but they don't have like multiple doctor's degrees and considered like among the top people in the world. But it was very real and powerful for you. And the odd thing for me, it made me feel so close to you and feel so much deeper admiration, because I was feeling, wow, that this is the doctor you want to have, and that you have so much to offer that you don't realize. To talk about where our thinking went on that hike and where you came out on
that. I think what I realized that I care about patients. That's the reason that I was suffering from, and the feeling of inadequate or embarrassed or guilty all came from because I do care about my patients. And what I realized is that just working with you and from the other hikers, that it was very eye-opening for me that they were impressed at how much I care about my patients. And I think what I realized, that patients once they know that I'm listening to them and I care about them,
that I have feelings,
and I have feeling, so then it means a lot for them, rather than me being like curing them. I think of course they would have liked, and I would have wished that there was a cure, but I think at that point for them just connecting with the patients was crucially important, which I was not, it was not in my equation.
Yeah.
Before talking to you and listening to the other people.
Yeah, the paradox was that you had everything to offer and thought you had nothing to offer. And when you came to that discovery, it was so moving for me. When I was a medical student, as you know, I was probably, I don't want to be narcissistic and say I was the worst Stanford medical student of all time, but I was certainly very close to that. And I was just a horrible, disrespectful, I cut classes, I was awful. I never should have gone to medical school, but the one person I really loved was Ellen Barber. and he was the chief of outpatient medicine. And he discovered what you discovered, that for all the technology that you have, most people need something more than that. And the people who came to the Stanford outpatient clinic came because no one could diagnose them. And they came from all over the Western United States, the most difficult patients, and almost none of them had anything wrong with them. They just had chronic pain and dizziness. And he wrote a book called Caring for Patients. You talk about caring, to show doctors how sometimes you have to let go of the medical model and take a human model and ask these patients what's going on in your life that's been bothering you, the time the pain came on, or the time the dizziness came on. And we saw many of those patients, 50% of them recover entirely from this chronic dizziness or back pain or belly pain or whatever they had, once they began to talk about that they were lonely because the kids went to college. I had a patient who was going to be the first open heart surgery patient at Stanford, and it was going to be very risky because he had intractable angina.
I see.
And it was felt to be hopeless. And so he was going to be experiment to see if, move the arteries around in the heart. At that time, I mean, it was brand new. No one even knew if he would survive. And then when I was talking to him, he was a mailman, this black mailman. And I just got a funny feeling talking to him because he was in so much chest pain. He couldn't do his route or anything. And then I said, just is there things bothering you, or in your life? He says, oh, my wife bosses me around and the kids boss me around, and it seems like everybody's putting me down all the time. And just on impulse, it was just a stupid thing to say. I said, do you know the difference between a Negro and a black man? And he says, well, what do you mean? I said, well, you sound more like a Negro than a black man. And this all probably sounds horribly politically correct, but I said, why are you letting all these people, put you down like this? And I just felt so much compassion for him. And then I presented him to this attending. Mark Perlroth was a young genius from National Institute of Mental Health, and he was a cardiology, young up-and-coming star at Stanford, and I had to present to him. And I said, there's just something about this that doesn't add up. And Mark looked at his EKGs and said, this guy never had a heart attack. Wow. This was all incorrectly diagnosed. Wow. And he had an infection of the pericardium. He had pericarditis.
I see. Wow.
And he shouldn't have open heart surgery. This would be a huge mistake. Wow. And so we went in, we talked to him for a little bit. And I said, why don't and he had an appointment the next week. And Mark said, do as Dr. Burns says, tell your wife that you're unhappy and that you love her, but you don't like getting bossed around all the time. And then bring your pills in with you next week. And he came back the next week, and it was odd. He says, Doc, I think I've been cured. My heart pain disappeared entirely. And I just told my wife that, I loved her, but I didn't like being put down all the time. And they brought in his medicines, and he had a bag. He must have had 2,000 pills in there. He was taking like 38 medicines a day or something. Wow. And so we just had a ceremony and just poured them into the wastebasket. But it was that thing that we got trained so much in the technology, and who in the world could have more technology than you, Amir? And yet you found that your heart had so much to offer. Well, we want to make this about you, and you had two other fantastic hikes and experiences with your patients and learning the human side of medicine and neurology.
But David, that was a really beautiful story that you told, and that we all can hear how much that patient really touched you.
Yeah.
You can see in your face, probably the audience don't, but I think what is lacking in the training of medical doctors in different countries is that we learn about all physiology and anatomy and how to treat, how to do the surgery. But what at least I have not any training, and was how to communicate with the patients during medical school. or even during residency. We learn from watching, our mentors and professors, but nobody comes and tells us like exactly what does empathy. I actually learned the empathy. What does that mean after graduation from my residency?
Wow.
I didn't know what is the definition of empathy and what is this empathy, or I heard the first time from you what is like thought empathy and feeling empathy. And I'm sure there are like thousands of doctors who don't know about this. We learn about how to treat the
But Amir,
disease.
can I ask you a question?
Yeah.
So when you were first learning, because I'm not a medical doctor, when you were first learning how to take a medical history when your patient was coming in for an intake, for example,
Yeah.
you weren't taught about how to make a connection or
No.
provide empathy to them
No,
as they were telling you their medical stories?
Now sounds like really,
That's really surprising.
really surprising, but to me it was like get the story, get the facts. I think as a medical student and resident, you want to get the facts and come to the conclusion and give the diagnosis and give the treatment. There's no room for they don't say that you don't have to empathize with the patients, but there's no equation for empathy during the training. It's like if you look at medical textbook, when you read about the different diseases, there's nothing written about you have to do empathy. I think maybe in the first chapter of the textbooks there are something, or if you are interested then you may read, but there's
some textbook or something.
Yeah, that's it.
My first job out of graduate school, I worked at the Rape Treatment Center in San Francisco, and residents came through to provide the medical care. And so someone would be raped and they would call the police, and then police would bring them to our clinic. And all the residents, I'm sad to say, I have had the exact same experience working with them. And they would come in and they would say, here's this, usually a woman who was raped, and they would be really uncomfortable. And they for a while they would literally say, what do I say to her? And I'd have to say to them, okay, walk in the room and say, I'm sorry this happened to you. And then start asking them your medical questions. And then they would walk in and say exactly that. I'm sorry this happened to you. And then go right into sort of robot mode of gathering the data. It was a sad aspect.
I think at least I'm talking about myself and my own training. I think it was very robot-like, get the facts from the patients to make a change in their life, just come with the conclusion and just like they,
Well, you have two other amazing stories, and it's just been a joy to me to see you're learning the 5 secrets of effective communication, developing phenomenal empathy and communication techniques, and using them not only in your interactions with patients but with colleagues. It's like having your third PhD, you might say. And tell us about a couple more of the amazing experiences you've had.
Yeah, this is a recent patient. Basically, he was in his late 20s. He came and, I should say that after our training, and I work at Kaiser, and they teach us how to do empathy, etc. But this is, and based on both of these, when I went and see this patient, so I opened the door, I greet, and I just try to break the ice and talk, and I greeted with this patient who just opened the door. He had a dark eyeglass, and I introduced myself and greeted and smiled, and he just shrugged his shoulders. And I usually ask from my patients the first question after this icebreaker, that what is your goal from this clinic visit? What would you like to achieve? What you want to get out of this hour? And he just even didn't make eye contact with me and said, I do not know what I'm here. And it was very awkward conversation after that, and I tried to understand him, and I told him that, can you tell me more? And he said, I think my primary care is sick and tired of me, and that's his reason for sending me to you, because he doesn't know what to do with me. And I said, wow, that's must have sound like very painful to you. And I don't want to go to the details of how the conversation went. And he told me that I don't know I'm here. And I said that, and then after that, he said, you know what? I think I'm like wasting my time and money with you, to be honest. And and then I tried to be respectful to his time and money and said that, you know, I really like helping you, but I would like to be respectful to you. And if you feel strongly that this visit will not be helpful, I can, I can ask them to give back your copay and go. And he told me, see, even you don't want to see me. You are not interested in me. And then it started like that. And long story short, he was he was not working. He was in rehab. He had severe sleep problems and daily headache, very bad headache. He couldn't keep a job.
And addiction.
And addiction. But he was in rehab in and
Yeah.
out. So what I did, it was not very easy, to be honest.
It was a challenging
It was
patient.
a challenging patient, but I used all of the, the thought empathy and the disarming techniques and the feeling empathy. I tried to do
Stroking.
my best, stroking and everything. And at the end of the visit, this I forgot to tell. So he started crying like from the very beginning. So when I started, and he said, "Oh my God, I've never cried in other doctor's visit. It's so strange. I don't know why I'm crying." And it went like that. And what I did, I tried to understand and listen and do empathy. It finished, and I thought, I wasn't honestly sure that how did I do. I thought that he will be like, not very happy, because I was offering help and said, see, you are not even helping me. So like, I'm at like volleyball, you are just sending me to somebody else. So he went, and after the just maybe like an hour after he left the clinic, he wrote me that, I just wanted to say thanks for listening to me today. You are the first Kaiser doctor I've ever felt who cared about me and my condition. It means a lot to me. I'm actually hopeful. And he wrote this. So, and I was like, very touched and, very happy, but I did not know. I basically did nothing. I thought that I did nothing for this patient. I told him that, you are going to see, I'm going to refer you to a pain doctor I'm going to refer you to a sleep doctor. And then if your sleep gets better, your headache will most likely get better. That was like my final conclusion and advice for the patient. I felt that I did nothing for the patient, but this is what he felt. And what I did, I just did the empathy and, the disarming. And, I mean, the story is that how using these techniques, which I was never learned in the medical school, how they are affecting patients' quality of life. And, if he's hopeful, then he's going to be proactive and go do something. And I think that was, what I learned. That was my real experience recently.
I love that story, and there are two takeaway messages from my point of view. One is, it sounds like what's happening, you've been a fantastic technician from the time you were a brilliant medical student, PhD student, but now you're moving beyond technician to healer, and by bringing the human dimension, and specifically by using the 5 secrets of effective communication, which, by the way, is hard to learn. And you've come on many hikes and really worked at mastering these skills. Another, which I love to see, and that's why we're doing this podcast, because there's a lot of doctors, human beings in general, who really need these skills. And that the other thing that you said, you gave him nothing.
Yeah, that was my feeling, really. I thought that I did nothing for this man.
Yeah, and that's what I call the 5 secrets, the nothing technique. And we've talked about this on our recent podcast on how to help and how not to help. Right. And that you give the patient nothing. You give them 0, but zero in on what they're saying. Show an openness to what they have to say, disarm them, ask questions, give them a great audience, and give them nothing. And in giving people nothing, we're often giving people everything.
Everything, something he'd never experienced from any other Kaiser doctor.
Because he's probably an irritating individual. I have a right to throw stones because I myself am a very irritating individual, as Rhonda knows so well. But now I don't even remember what I was going to say. I'm demented and irritating.
Well, here's this really challenging patient.
Yeah, a challenging patient, and you listen.
And you listen to him, and you're feeling like, oh, I'm not giving him anything, but really you're giving him your heart, and you're giving him your ear.
Yeah.
And he walked out and said, wow, no one's ever given me that before.
It's just a beautiful thing, and he doesn't get it from anyone else. That's what I meant. Like, he's probably turning everyone off because he's whining, complaining, criticizing. So everyone gets turned off. Tries
not
to
just
get
his
rid of
doctors,
him.
everyone in his life. You're saying?
Huh?
You're not saying just his doctors, but everyone.
Everyone
in
in his life.
Yeah.
And so that might have been the first moment of intimacy he's ever had, or the first in years, if not decades.
But I think it says something also too about you, Amir. And my experience of you on the hike is your kindness and warmth,
humility,
and
gentleness.
Yes, my experience.
You are stroking me. Then I will open up more.
Yeah. Tell us another story. Or are you done with this one?
Yeah, I think what I learned is just to listen. And then he felt that I'm caring. I think that was like missing, because I tried my best, and then he thought that I am caring about him, and he was hopeful. I think that was the
But
listen
you weren't
to myself.
pretending to hope.
I was not.
I mean, you were
I was
pretending
genuine,
to care in order to manipulate him.
Yeah, that's
or to
right.
get him to be quiet or blah blah blah. You were bona fide, actually caring.
Yeah, I did. Yeah, I was caring.
How did that make you feel to get that email from him?
It felt me a lot, actually. I thought it made my day, I should say. And this is somewhat related story. I was in a dinner with two of my residency friends from UC San Diego, and they are like internists, hospitalists. I asked them last night that how's it going? What kind, how's your life? How do you like, or what do you dislike with your work? And then they said that the situations which are patients drug addict and come and ask for difficult patient, that's the most difficult part of my job, how to communicate with these patients. So then they said that we never had, I talked about, how you can, listen to them and empathy, and then we said we never had this training. So many doctors, I'm sure, they have no clue. They may have not even heard of how to, listen, what is active listening, what is thought empathy, disarming. So that's why that not only affects the patient care, but also that's the hardest part of being a doctor, which is you cannot communicate, and they complain to you, and they are unhappy, you're unhappy. So if somebody like drug addict, which like this patient, who is happy and grateful and tells you, that makes my day too, and I feel like I'm doing something, although I didn't feel so, but apparently I did. So
one of the, I feel like underneath, some people hate me for this, but I feel like underneath the techniques we teach in team CBT are spiritual ideas, that these are all spiritual techniques. And one of them is that we're one. That's a kind of a mystical, the universe is one, we're all one. And I never knew what that meant, because I said, well, it's not true that we're all one, because I'm David, right? And what is this? Pan. And no one ever called me Pan, and no one ever called this David. Like, we're separate, see? So I can never understand, what does it mean that the universe is one? It's just like some mystical mumbo-jumbo. But then when we hear your story, that you and the patient were one, because in giving to him, and giving him joy and feeling cared about, then you receive joy.
That's right, yeah, that's correct. Yeah.
And that when you don't handle it well, then the patient goes away, or your loved one goes away angry, irritable, then you feel that same burden. Then you're carrying that same
it's a drain.
It's a drain.
Instead of being enthusiastic and exhilarated.
Yeah.
And fed.
So it's just not a technical thing for physicians who might be listening, but for everybody. And it's not just a methodology of communication techniques, it's a spiritual thing too. Well, you had one more amazing story about when you then became enlightened and you were at the lake today on the hike and began walking across the water. And that really impressed me.
That did impress all the people who were fishing.
And I droned. So this is also a very common challenge when doctors, do with good intention for the patients and something horrible happens. And that's a very devastating situation. I'm sure every doctor who's listening have some stories to tell. So this is a recent patient of mine, another recent patient of mine. She was in her early 20s and she came with severe acute onset weakness with pain and was diagnosed with, she has addiction to alcohol. And then everybody thought that her disease, her weakness is because of the alcohol and said that you have neuropathy, go home, just don't drink. And I was contacted and, because of, alcohol neuropathy doesn't cause like severe acute onset weakness in one leg and then not the other. So long story short.
Just for the listeners, one great thing about a good neurologist is you can tell from the history when a diagnosis is correct and incorrect. And you were saying that this cannot be due to her drinking.
Yeah.
The way that the weakness is shifting from leg to leg, this is a different and organic cause, another organic cause.
That's correct. So she actually had an inflammation in her peripheral nerves, which caused like basically destroying her nerves. And I treated her with steroids, with strong steroids. And then I explained to her, the benefits and risks, and and then she went home. She was not able to walk.
The benefit and risks of what?
Of the medications.
Of the meds.
So when she went home and then got medication, she was actually like almost completely cured in terms of her weakness. She wasn't able to walk when she came in to see me. And then she actually went back to work. And then she restarted drinking also heavily. And then she, after several months, she came to me, and when I watched her, so she had a very awkward type of walking, basically limping in one side. And then in the middle, when we were talking, in the middle of like this visit and prior, so she had fracture in her, her bone, her feet. And then I thought that, I used to think that, oh, this is probably because of the fracture. But when I saw her, she had she couldn't extend the hip. And I thought that, oh my God, this is like a side effects of the medication, steroids. And what happened, I thought immediately that her femur bone, like the femoral head bone, collapsed.
That's the top of the leg where it joins into the hip.
Yeah. So basically, both of the bones, like the hip bone, like collapsed. And then...
Isn't that horrible?
Wow. Yeah.
It was...
Sounds incredibly painful.
And then I got...
Could she get out of bed?
She was able to walk, but she was walking awkward. What we call antalgic pain, which means that you try to walk to make it less painful, but you limp basically. And then I told her that this could be complication of the medication, but I need to do a X-ray to make sure this is it. So I felt you ask how did I feel? I felt so bad and so sad that I actually coming back home, I got very bad headache because of what I felt so bad. And I felt like I felt guilty. I felt that I'm not a good doctor. I felt that this shouldn't have happened. I took all of the blame to myself. I felt incompetent. And also I felt scared too, because they know me. I think I knew that they know me, and they they know that I care about them, but if they know that this is maybe because of the complications of the medication, then they say that, yeah, they could sue me basically. And I had like very bad feeling. And when I came and worked with you in the hike, and I realized that, it's like maybe my cognitive distortion or generalization, that I'm like incompetent because something happened, and I was, blaming to myself, not seeing the positives, and all of those. So when it made me feel better, and I went to see her. I asked her to come and see me, and I was prepared to, to be, accept what is my responsibility and what has happened, and I express my own feeling. I feel statements of what happened, and then I was anxious too. However, I don't think I have shared this part with you. So when she came with her mom, and I told her that, there's a whole, different skill set that I have learned from you. Is about how to give a bad news, and I gave that bad news to her, and try to be empathic with her. So it finished like very, very well. So she understood, her mom understood. I think I did not feel that they had any like negative feeling against me. I think, which is true too, because I told her that this could be because of medication or because of the alcohol. And I told her that I should have told you that if you drink alcohol, this is going to happen to you, and I'm sorry I didn't tell you. And she said that you did tell us. You told us. I had forgot about it.
Yeah, she came to your defense.
Yeah, she came to defend me. I mean, I think this happens a lot to the patients. And then what I have learned, and I think most doctors know, when the patients sue or get angry, mad at at doctors, it's not about what you did, it's about how you come across and how you empathize with them, or how do you understand them. If you are cold and say, that thing happened, sorry,
or you defend yourself,
you defend yourself, or then or hide, or don't bring it up and then blame others. So I think it's just the opposite of what happened.
So you want someone to care, the compassion.
Exactly.
So
if you feel that you care,
so hungry for compassion. And I once treated, I might have told you, a man was referred to me and said, this is America's top malpractice attorney. And he specialized in suing doctors. And he had lost only one case in his entire career. And so I showed he was very interested in the 5 secrets of effective communication and the disarming technique, and how you accept the truth and criticism. And I told him, my students and colleagues are always saying, if I use these 5 secrets and I agree with the patient who's criticizing me, both in medicine side or the psychology side, psychiatry side, won't I just open myself up for lawsuits? I said, well, I'll give you the answer, David, but I don't want you to tell your colleagues, because if they know the answer, I'll be out of business. But the answer is if doctors learned, like you've learned, the 5 secrets of effective communication, and you find truth in what the patients tell you. He said, I'd be out of business. And if you ever had to go and testify in court, and you use the 5 secrets against some aggressive attorney cross-examining you, and you disarm and stroke, a jury will never find you guilty. He says people almost never sue due to malpractice. They only sue for one reason: the doctor wouldn't listen. And then they come to me. I have a way of making doctors listen.
I see.
It was so interesting, and your story is a beautiful example of that. And so there's a fantastically important bottom line to today's podcast, which Rhonda will now reveal.
We've spent a lot with Fabrice in episodes 65 to 70, and various other times we've talked about the technique of how do you learn what is the 5 secrets? How do you learn the 5 secrets? And how difficult is it? And I think, Amir, this is a really lovely, so milk toast, but this is a really powerful example of how you use the 5 secrets in real life, with challenging patients, or when you've made a mistake, or maybe it was a mistake, but when you feel like you've done something wrong, and how effective and important it is. And I think it's great to have a lot of these different examples. So in the medical profession, we're going to have other people talking about it with, Amy talked about it within a high school setting, and I think it's really important for people to hear how the 5 secrets actually work.
Yeah, I'm just so proud to have you on today's podcast as my friend and an esteemed colleague, and just really want to thank you for opening our hearts up and our minds as well.
I would like to thank you so much for everything, and what I learned, 5 effective of effective communication. It has actually transformed my practice, how I communicate and connect with my patients. It not only affected their life, it affects my life too. When they are unhappy,
oh yeah,
it reflects to me,
yeah,
and I get unhappy.
Yeah, right.
So yeah,
I'm
like what you said,
and then you take it home, and then
So
your family is unhappy.
And then you don't like your job because patients are complaining. But if you make them feel better, then everybody is happy. And I think this is very important. This is like a gap unfortunately, in our training. And I wish I could have learned earlier, or I wish my colleagues
Amir,
learn
do you think
about
all
this.
medical students need to learn the 5 secrets of effective
Definitely. I think not only they need to learn, I think they need to know that this is lacking, and they need to learn, and they need to practice, and to be supervised.
Easy.
Yeah. Because this is crucially important in daily practice. Because I think most doctors, they know how to treat like pneumonia or migraine, CHF, exactly. But so that's not the problem. The problem is that they don't know how to connect and communicate with the patients and make them feel listened.
Can I just jump in with a question?
You've been talking too much.
I've been talking too much. So a long time ago, I took the EMT course, and as part of it, you had to go out on a ride along with the emergency responders.
Oh,
and so I remember once we went into this apartment, and there was an old man on the ground, and he had a heart attack or something. And so they told me, okay, why don't you go do chest compressions, which basically meant the guy was dead because they were having like this. So, but you still do the chest compressions, and we were going to the hospital. And I remember when we got to the hospital, there was a nurse who greeted us, and she asked how old the man was. And one of the paramedics said, like 78 or something. And she like kind of jumped for joy or something. And I asked her later, like, what happened? And she said, oh, we had a bet on how old this guy was going to be. And and this person's family was following us, so they kind of saw that. And I was asking one of the firemen afterwards, like, what do you think of that? And he was like, look, if you see the stuff we see all the time, like, you just have to distance yourself from it. This is how you stay sane. And so I'm curious, just briefly, because I know it's the end of this podcast, but I mean, when you're doing the 5 secrets, and particularly for Amir, with the population that you're seeing, like, how do you find that balance between being empathic and compassionate, and not getting pulled into perhaps like the difficulty that the patients,
the pain,
the pain of the patients? And I think it's important to say, like, the doctors that refuse to empathize, they might not be awful people. It might just be that's their way of protecting themselves from the everyday realities of dealing with people who are going through a lot of, very, very difficult things. So that's kind of the end of the podcast, but I'm curious, any thoughts on that?
I think it's a very, very difficult, complicated situation. I think if you don't know, just my experience, if I don't know how to communicate with the patients, then I carry more pain with myself. And then in order to protect myself, I have to disconnect myself from the patients. That's why that's the end of it. So because you cannot survive having that much pain and carrying with you all the time. But if you effectively communicate with the patients and make them feel better, you look at them as a human being and do your best, it's a very, very different experience. The amount of pain you may take with you, but it's not it's uncomparable with
It's like
the
a
time.
joyous pain.
Yeah, it's a joyous pain, yeah. And then it makes you humble. It makes me humble to, it becomes philosophical of like, seeing that, I'm not able to change the world, but I'm doing my best for every individual patient to provide the care that they need. I may not be able to cure this Lou Gehrig disease, but I've done my best, and I'm doing not only to provide the best care in terms of what they need physically, in terms of, say, physical therapy, etc., but I'm there to listen and care and make them feel and heard, not the patient, but also the family. Then what comes back is the joy and gratitude from the patients, and we become very close. So that makes my life better too.
Yeah. We'll talk about this a little bit more, maybe on the next podcast.
But that was a wonderful question. I love that question, and I love your answer. I mean, that was very powerful.
It's like a paradoxical,
Yes,
another paradoxical for you.
It's a paradox, but I think in general, it's not just doctors, but that all of us are closed off. We're asleep most of the time. And then we look at the surface. See, I'm looking at all these surfaces here. But underneath, there can be tears and real pain that we hide from ourselves, and that people hide from us. And that tuning into that, if we could really tune into that, we might be crying all day long to see how much pain that people have. But it would be a joyous kind of.
I mean, you were on the verge of tears, or with talking about that patient earlier.
And that was like just a wonderful, a wonderful thing. And then I didn't hear from him for about 6 months, and then I got a notification that his son had died unexpectedly, and could I come to the funeral? And so I went to the funeral, and then someone came up and tapped on my shoulder and said, "This fellow, whose name I don't even remember, Jerome or something, seems to be having a heart attack out by his son's casket or something like that. He said he needs your help." And once again, he was walling off the tears. I went and hugged him. I said, I think you really need to let go and let the tears out. And then he started sobbing, grabbed me. We were just kind of hugging and crying together. And I said, "Thank you, doctor. My pain has just disappeared again." But it's my only sadness is that it's hard to be that open, that we spend so much of our lives dead, asleep, and then every now and then we wake up. Well, time for commercial message at the end of the podcast. If you're looking for more help with this, you could pick up my book, Feeling Good Together, and do the written exercises. I'll put a link to it in the show notes, or you could go to my website, feelinggood.com, and find that book on the books page. It's very inexpensive at Amazon. And then if you're a therapist wanting further training, I'm going to give on February 9th a wonderful one-day program with my most fantastic colleague, Jill Levitt, Dr. Jill Levitt, a one-day workshop on dealing with therapeutic resistance in your patients. I think it's the most important topic in all of psychotherapy. And if you're interested, go to my website, feelinggood.com, and go to the workshop tab, and you'll get all the details. But it's a one-day program. You can come in Palo Alto in person, or you can join live streaming online from anywhere in the world. Thank you, Amir.
Thank you so much.
It was just so
Thanks
great
for
today. Yeah. Wow.
Thank you,
Dave.
Yeah.
And thank you to all our listeners. Till next time.
Steve was going to be on our next podcast. Amir just asked Steve, as an audience member, how did you feel about this podcast?
And I'm a patient now, and I was laying down on the floor crying, Amir, wishing I had a doctor that cared about me like you, that someone would ask me those questions and just be concerned and look at me as something besides a body with cancer. that it would be a human being was overwhelming. Thanks so much.
Sure, I must have been very, very difficult for you. It's that seems like you have had doctors who you didn't feel that they didn't care enough about you.
Yeah, I think I've had really good technicians, like David was saying, that they've been good technical, but I haven't been. In the last year and a half, I can actually remember two times where someone actually just asked me how I was doing as a human being, and one was a pharmacist. So it was, it was shocking. I told him, I want your address because I'm going to write you a note, a thank you note that you called me up to follow up and see how I'm actually feeling. So yeah, so I think they're good technicians, but as a patient, I really just want to be cared for, and felt lacking.
Thank you so much for sharing your experience.
Yeah, and
your feeling.
Well, thank you. And I wish you were an oncologist.
Thanks, everyone.
Thank you.
This has been another episode of the Feeling Good podcast. For more information, visit Dr. Burns' website at feelinggood.com, where you will find the show notes for this episode under the podcast page. You will also find archives of previous episodes and many resources for therapists and non-therapists. We welcome your comments and questions. If you want to support the show, please share the podcast with people who might benefit from it. You could also go to iTunes and leave a 5-star rating. The theme music is Gypsy Jazz in Paris, 1935, composed and performed by Brett Van Donsel. I am your host, Rhonda Borowski. We hope you enjoyed this episode. I invite you to join us next time for another episode of the Feeling Good podcast.